Thank you, Bombay Orthopedic Society, for your very kind invitation to allow me to speak on the interesting subject of why we need different osteotomies for differing location and severity of deformities in medial compartment osteoarthritis of the knee. The whole premise is based on both the radiological and clinical examinations. Well, first of all, as we start, Dr. Koshino showed very elegantly that the osteotomy can allow cartilage to regenerate. So do not listen to your arthroplastic colleagues. This is going to be a recurring refrain in my talk. So today what's happening is 90 to 100% of the literature is based on the medial opening wedge high tibial osteotomy. It is fantastic. But when we see the presentation of medial compartment osteoarthritis in our OPD, they may present to us with mild, moderate, severe, or horrendous or grotesque deformities. So can one osteotomy do justice to all? When we take full-length X-rays, which is a sine qua non, which is the very basis, we can see the mechanical axis is deviating either mildly, moderately, severely, or tremendously. So can one osteotomy correct all these deformities? Obviously, one HTO cannot solve all these problems, perhaps without creating newer ones. So this talk is based on the 6 different osteotomies that I have been performing since the last 32 odd years. The first one is the focal dome osteotomy, which was described by Dr. Paley, done with the Ilizarov fixator. For the first 15 years, I exclusively performed this osteotomy, and it has got tremendous advantages. It's a little difficult to master, but the rewards are innumerable. The second is the opening wedge high tibial osteotomy with the Tomofix system, which is ideal, which I have been doing since the year 2009. The third is the distal femoral osteotomy, which has now come into vogue and is very popular of late and is subscribed for all large deformities with MAD greater than 0, and I'll like to place this in its true perspective. The fourth and the fifth and the sixth ones are newer osteotomies. You probably have not heard of them, but there's always a beginning. So this is the Tibial Condylar Valgus Osteotomy, the intra-articular. All of these are intra-articular osteotomies. The TCVO is an intra-articular osteotomy fixed with a plate. When we need to correct really large deformities, which also have an intra-articular component, then we can add a second osteotomy, which is the TCVO with an extra-articular osteotomy, which I will be explaining briefly. And finally, an elegant solution which allows us to correct very large deformities, both of the intra-articular and extra-articular kind, in the tibia with a single osteotomy, which is the focal dome condylar osteotomy. So how do we choose which one? So we categorize the deformities as a primary deformity, which is a coronal plane varus, which is measured by the MAD, which is measured by MPTA, measured by MLDFA, and of course the hip knee ankle angle. The secondary deformities are really not well known, and they are the intra-articular ones, and this is where we'll turn our attention to. They're based on 2 measurements radiological we take, and that's the joint line convergence angle, which is angle drawn to the tangentially to the femoral and tibial condyles, like so, and a large JLCA points to an intra-articular deformity. And the second one is a condylar plateau angle, which is, we are familiar with this from the Blount's literature, in which there is a depression of the medial tibial condyle. So we draw a tangential line to the tibial, medial and lateral condyles. They normally should be more or less collinear. If there is a large angle between the two of them, it suggests that there is an intra-articular deformity. And in its maximum extent, this is seen as the pagoda tibia. Now the tertiary deformities so far, which have not been well understood or have not been taken into consideration, are the sagittal, axial and rotational deformities. The sagittal deformity is the fixed flexion deformity, which was supposed to be a contraindication in the years ago, which is no longer. I'll show you. The axial, that is the limb may be either short or longer with osteoarthritis, or the rotational deformities such as an intorsion, and we have to take all of these into consideration. Some ancillary deformities like the knee and the ankle joint line orientation should also be considered before deciding which osteotomy is best. And a certain clue, if you are really hooked onto the medial opening wedge high tibial osteotomy, is to find out the angle alpha based on the Miniachi method and the amount of opening of the wedge, which will suggest to you whether really this is the best way, whether the medial opening wedge is the only osteotomy that can work in all cases. So the choice of osteotomy is based on whether the primary, secondary or tertiary deformities are present. That is a small or a large varus, an intra-articular which is present or absent, and the sagittal axial or rotational which are present or absent. The small varus is when the mechanical axis deviation is greater than 0, that is the mechanical axis passes through the knee joint, and a large one is when it passes from the medial side. A secondary deformity is based on the JLCA and CPA. The JLCA lesser than 5 and the condylar plateau angle greater than -3, that's it's not present. And the tertiary deformities, either procurvatum or recurvatum, the limb may be short or long, or there may be internal or external rotation. So this is an algorithm which we developed, which is not that difficult, so bear with me. This is a primary varus deformity. If it is small, without a secondary intra-articular deformity and without a tertiary sagittal axial or rotational deformity, the medial opening wedge is the ideal surgery. If the varus is large, but there's no intra-articular deformity, but there is a tertiary deformity like a large rotation or an axial deformity, then the focal dome condylar osteotomy will help you to achieve the result. Let's come to the intra-articular ones. When the primary deformity is varus with an intra-articular but without a tertiary deformity, then a tibial condylar valgus osteotomy is the ideal osteotomy. And finally, when you have a large deformity which is present in the primary, secondary and tertiary planes, in the coronal, in the sagittal, axial, rotational and intra-articular, then the TCVO combined with the second osteotomy may do the job. And this is the entire algorithm. So let's take a brief look at the extra-articular osteotomies. This is the medial opening wedge, this is the dome osteotomy in the center, and this is the distal femoral osteotomy when combined with a tibial osteotomy. The intra-articular ones are the L-shaped TCVO. The second one is the TCVO combined with an extra-articular osteotomy, and the third one is the focal dome condylar. So let us take a look at the dome osteotomy, which was popularized by Mackay, was very popular in India. And I have used the modern version of this. This is the focal dome since 1991. It has many advantages. This is an orthopedic surgeon with a large mechanical axis deviation, and the Ilizarov fixator fixes a curved or a dome-shaped osteotomy, which is translated a little bit laterally and is rotated externally. You can see this by the seeming posterior translation, which allows a better shift of the mechanical axis. And here he is with a full correction. In certain circumstances, the focal dome is really wonderful, as in this amputee with the normal leg being in varus. So the focal dome allows a very good bony, contact and full strength to full weight bear from the very beginning, as this gentleman could. We can do it in bilateral cases simultaneously, though sometimes with the tomofix we can do it with thin, lean individuals. Now let's come to interesting combinations. When you have a tertiary deformity, that's you have a varus with a sagittal deformity which has got procurvatum or recurvatum, rotation and shortening, as in this professor of medicine. You can see his full length x-ray, the varus, there is no intra-articular deformity, but there is intorsion and there is shortening. So we performed a circular fixator, we performed an osteotomy in which we corrected the varus, we corrected the length and we corrected the rotation. And here he is with this complete correction and ability to perform well. He was working from the second or the third week after surgery, and now he has full function after 6 to 7 years without problems. You can also have this combination of the three planes, as in this patient with poliomyelitis. The polio limb is short, the normal limb is 4 centimeters longer, and this is long leg arthritis. It is compensating by bearing the brunt of all the body weight. Hence he's developed arthritis. So if we just do a dome or an opening wedge or whatever, this long limb will become longer. So what we did, we added a shortening. We shortened the limb, fixed it with the Ilizarov, took it into valgus and corrected the rotation as well. And this patient is free from pain for at least 26 years because the limb lengths have become equal and it's in valgus now. You can also have tertiary deformities along with varus. This anesthetist had a varus, and you can see the slope is reduced, and he's got a recurvatum of 12 degrees. He's in a lot of pain. So at 42 years. So with the help of the external fixator, we corrected the varus, we corrected the tibial slope, And now you can see that he's redeveloped the slope. And by redeveloping the slope, because he had a PCL laxity, that has become tightened, the PCL. And it has allowed him to resume his badminton in 4.5 months after the surgery. So, having done with the dome, which I performed first for the first 15 years with great success, then I realized that external fixation is not for all patients. So I decided to open my mind, and this is the beginning of the journey that I am sharing with you. So the medial opening wedge tibial osteotomy was first started in France in 1951. Philippe Hernigu was its biggest proponent, and it got its modern avatar from the, with the Tomofix system with Lobenhofer and Stobley in the year 2002, and no wonder it is so popular today. It's ideal for a small varus. As I'll show you, this is an orthopedic surgeon. His mechanical axis deviation is 34%, and he's in a lot of pain and he wants to run. So he got this high tibial osteotomy with a very small wedge. This is only 5.5 millimeters, which took his mechanical axis to only 54. And therefore, he was able to run, and is today 4.5 years after the surgery, he is able to run a full marathon. And this is ideal for people who aspire for high level of activity. Do not overcorrect into valgus, okay? And there are a lot of papers which also tell us that, even taking it to neutral can improve the cartilage composition. And for athletes, you don't want to overcorrect. But you can overcorrect in older people, like this elderly lady who had this, overcorrection up to 66%. She's completely free from pain and there are no symptoms. But when you overcorrect, you can develop these hinge fractures, as she developed the type 3, in which the fracture went up into the articular surface. And therefore it is better not to do it. So a type 1 is when it goes to the lateral cortex. Type 2 is when it goes down below the tibial head, which is the unstable one and can result in excess varus deformity. And the type 3 goes into the joint, which is easy to detect and correct with the help of screws. So, an elderly lady like this with a large varus, if we use the medial opening wedge and give a large correction and they walk very early, they can develop this type 2 fracture. And all you have to do is keep them partial weight bearing for some time. The type 1 lateral cortex is not a problem, and it can be easily corrected by what's known as the golden screw. You use the non-locking screw to compress the plate, and it compresses the hinge over here. Sometimes the medial opening wedge is not the ideal indication. This lady has a high condylar plateau angle, which I could not detect before the year 2014. And we've spoken about this, and we've done the medial opening wedge, but I'm worried that the teeter-totter effect in the joint will persist and she may not get a long-term result. So the opening wedge is ideal for mild varus, but not for severe deformities. Why not? Because if you correct a large wedge, you can develop hinge fractures. The bone may take a long time to heal. You can have patellofemoral degeneration, excess pressure in the patellofemoral joint. It is also proved that if the MPTA goes beyond 95 degrees, you can get ACL degeneration, excess loading on the anterior cruciate ligament. And finally, this big thing about the knee joint line orientation, greater than 5 degrees can create difficulties, especially in those who are high demand. And if you open a large wedge, let's say 20 millimeters, you can end up with a 1 centimeter leg length difference. And if you don't measure this carefully post-operatively, the patient can go into fixed flexion deformity on the operated leg. So, due to this understanding of KJLO, the femur plus tibial osteotomy became popular from the Mayo Clinic in the year 2002, and rightfully so. It retains the knee joint line orientation. This gentleman could barely walk. He had a large deformity in the femur and the tibia. So obviously he was a candidate for a femoral osteotomy, and this osteotomy, which I'll be talking about soon, in the tibia, which corrected his axis nicely to neutral, and it has given him complete relief of pain, and he's really doing well. But the problem is that sometimes in elderly people, we can't do both the osteotomies in the same stage, and it's a lot of surgery. So it may be better to reserve it for those people who have, high demands. The distal femoral osteotomy is ideal not only for the, varus, but also for the valgus, as in this case, this is somebody with a lot of pain with valgus. You can perform this from the medial side, a closing wedge biplanar osteotomy with the tomofix system, and give him a perfect correction and complete freedom from pain. So the opening wedge is ideal for mild varus, not for the secondary and tertiary, which brings us finally to the intra-articular osteotomies, which is the TCVO, started in Nagasaki by Professor Chiba and popularized by Professor Teramoto. We learned about this in the year 2014. Very few articles in the English literature. The problem we know is that what the mind does not know, the eye cannot see. So how do you diagnose an intra-articular? Clinically, when there is a large varus with a dynamic varus gait, and you can elicit medial lateral laxity. Now take a look at this lady in walking. This is a large lateral thrust. This is medial lateral laxity on clinical exam, exacerbated under anesthesia and also recorded under the C-arm, in which there is a lot of teeter-totter. This gives you a clue that it's an intra-articular deformity. Plus, we also spoke that radiologically, with an increased mechanical axis deviation, an increased JLCA and CPA points to this deformity. A large MAD, a large JLCA, and a large CPA. So an intra-articular osteotomy is, this is the principle. This is a teeter-totter effect in the joint. We perform an L-shaped osteotomy, which elevates the medial condyle and it reduces the teeter-totter. It does not completely eliminate, and it may or may not completely correct the joint line, the mechanical axis. So this is the intra-articular L-shaped osteotomy. This is how it opens. Now, just a couple of examples. This lady had large deformities. She could barely walk. So here she is, and very miserable walk. So we performed on the right side a dome osteotomy, corrected the sagittal plane as well with a focal dome fixed with a plate, and on the left side this is the L-shaped medial, the TCVO, which stabilizes the joints. The importance is to stabilize the joints, reduce the bending of the wrist. This is her walking wonderfully well, completely free from pain. Sometimes the TCVO cannot completely correct the mechanical axis to beyond the neutral or to the Fujisawa point. So, the TCVO can give us good correction, decent correction of the MAD, very good correction of the intra-articular, doesn't overcorrect the MPTA. So, how do we deal with this undercorrection? So we have thought about how to add and when to add a second osteotomy, which can be a closing wedge, an opening wedge, or a dome. So I added a closing wedge osteotomy in the same plate beneath the TCVO in this lady, and we managed to come barely up to neutral. Now she's walking really well despite what seems to be a little residual varus, because there is no instability in the joint anymore. So this is a different way of thinking of that, reducing the degenerative instability. Now sometimes with large deformities we can add a second extra-articular one, as in this case. You can see the large deformity, the teeter-totter, and we perform the intra-articular one first, and we stabilize it with X-fix pins. It reduces the teeter, and we add a second osteotomy an inch and a half below the tuberosity and correct the mechanical axis. Completely. You can see this lady and her, high pagoda tibia condylar plateau angle. Lateral thrust, and here she is with the fixator. We can see in this x-ray, small x-ray here, both the upper and the lower osteotomies, and she has complete correction of both the intra-articular instability as well as the extra-articular deformity and pain. So the combination of osteotomies can treat all these types. And finally, I'll leave you with this new osteotomy that has come up in Japan in 2020. It allows us to correct both the intra-articular and extra-articular in a single osteotomy. This lady had a -5% MAD, and she would have needed a large correction, a second osteotomy. But with an elderly lady, she's 72, you can't do an X-fix. So this is a straight with a curved dome osteotomy, which with the help of a spreader and with hinge protection wires, we can correct it well beyond 66%. And as I said, in elderly people, you can overcorrect and get the task done with a single osteotomy. So I would like to end with a suggestion to young osteotomy surgeons who are dealing with medial compartment arthritis. I would recommend that you develop your expertise in at least 2 or 3 different osteotomies, have them in your armamentarium, and depending upon how the patient presents to you with his age, activity demands, and the kind and location and severity of deformities, you can do justice to the problem. Thank you.